You're welcome to this IQC or Internal Quality Control series that has been organized by VIQAP. Okay, so I hope you're here with your team and everyone so that we can demystify what internal quality control is, and we see what the world standard says about internal quality control. And the objective for this is that you'll understand what it is and you're able to implement it in your laboratory. So just not getting knowledge, but being able to transfer this knowledge into your laboratory. And if you're a student, of course, the objective remains to understand as much as possible so that when time comes and you are working in the field, you're able to understand what internal quality controls are and how to implement them in your lab. So yes, you're welcome. So my name is Viola Nachide. For introductions, I'm the managing director at VIQAP Consultancy Services. I don't know if you've seen us around, but I work with a team of many experts. We have experts in leadership, quality control, and technical fields, both in the laboratory and in the hospital space. So, stick around. I hope you're following all our channels on WhatsApp. We have a community there, on LinkedIn, on Facebook, Instagram, TikTok, and also X. So I hope you're following us there. If you're not, please do, so that you do not miss out on any upcoming events. All right, let's dive in. What is internal quality control? Today I'm just going to talk about what the standard says about this beautiful subject. We have a whole week to break it down. But today is just about what the ISO 15189 standard. This is a standard, the international standard that takes care of medical laboratories in terms of requirements for quality and competence. So I'm hoping that you have been trained on this standard because it's the international standard for all medical laboratories. Okay, and the fact that you are able to see this video, meaning you need training in it. And if you do not, just reach out to us at VIQAP. We shall be able to give you this training and a certificate. Okay, but today we are only going to look at 0.1% of what it says, and that is internal quality control. So by definition, the international standard for medical laboratories, specifying requirements for quality and competence, the 4th edition, that is 2022, which is the latest, says that internal quality control means, which is the same as quality control, these are internal procedures which monitor the testing process to verify the system is working correctly and gives confidence that the results are reliable enough to be released. Okay, so meaning whatever you put in your testing method to ensure that your results are reliable to be released. Okay, so what does the standard say about internal quality control? This is a clause 7.3.7. We're going to read it out. The first one, it recommends the laboratory shall, and by shall meaning it's a must, have a procedure to monitor the validity of results. Okay, so your lab, wherever you are, I hope you have a procedure to monitor the validity of results. And by validity of results, we mean in each and every testing method. And what do we mean by each and every testing method? That if your lab is running CBC, it has to have a procedure to ensure that those CBC results are okay. Okay, not just CBC, we even go down to HB. Okay, how do you monitor that the HB result is valid? So the resulting data shall be recorded in such a way that trends and shifts are detected, and where practicable, statistical techniques shall be applied to review the results. Okay, so if it's quantitative methods, you're releasing you have to ensure that those methods, the IQC procedure that you're using is recorded. So we need to have data to be able to see across a full month or across a certain period, how is this particular test faring? Okay, is it passing well, or are there technicalities? Are the results valid? So we need to see that statistically. All right. So this monitoring shall be planned and reviewed. Okay, so you can review monthly, you can review weekly, but of course the closer the better. So the laboratory shall have an internal quality control procedure for monitoring the ongoing validity of examination results according to specified criteria that verifies the attainment of the intended quality and ensures validity pertinent to clinical decision making. So when you are running our IQC, we have to ensure that we have a procedure to show that, you know what, the sodium I'm releasing from this laboratory is actually valid because I have run this internal quality control and I'm able to monitor it over a period of time, and from what I see from a statistical analysis point of view, the results are within range. Now, if you do not know how we statistically analyze IQC, don't worry, stick around. It's also something that we shall dive into. I think that is week 2. Yes, on how to show. But for now, we need to just know that you must. So what an exercise I usually recommend at this point, look through the tests that you have in your laboratory and ensure that you tick off each test that you have at least an internal quality control for each, okay, to monitor. Then we can move from there. Now that we have, how do we ensure that we monitor this to show validity? All right. Still about the standard, the intended clinical application of the examination should be considered, as the performance specification for the same measurement can differ in different clinical settings. Yes, so as you have an IQC, you consider the examination, okay? One could be using HbA1c to monitor for diagnostic purposes to show whether or not this one is diabetic or the other is not. Others could just be using it for clinical research. So you need to know the intended clinical application of this should be considered, as the performance specification for the same measurement can differ in different clinical settings. So yes, you need to know, okay, the cutoff point for what could I use? The cutoff point for HB so that the person is not hemoconcentration, yeah, is this in Kampala, but when you go to Mbale, it can be totally different because of the settings there. So you need to know. The procedure should also allow for detection of either lot-to-lot reagent or calibrator variations, or both of the examination method to enable this laboratory procedure. To enable this, the laboratory procedure should avoid lot change in IQC material in the same day run as either lot reagent or calibrator change, or both. So I think that's self-explanatory. So we have this thing of lot to lot because when you're changing your reagents from one lot number to another, you're required to run an internal quality control, an IQC material, to see that it's okay. So the standard is saying that in your procedure of working for IQC, this needs to be what? Needs to be, the lot-to-lot detection needs to be clear. Are you running on changing of the reagent? Are you running every morning? Whichever, you have to make sure the procedure allows for detection of lot-to-lot or calibrator variations, okay? And they say do not, try as much as possible not to change a reagent in the middle of the day or in the middle of a procedure, So that's what it's saying. The use of third-party IQC materials should be considered, either as an alternative to or in addition to control materials supplied by the reagent or instrument manufacturer. I'll read that again. The use of third-party IQC material should be considered either as an alternative to or in addition to control material supplied by the reagent or instrument manufacturer. I asked a question recently about which controls we are using, and most of us are using manufacturer controls. So the standard says, if you don't understand manufacturer controls, these are controls that are supplied by the person who gave you the method. I'll give an example. If Roche, for example, gives you a Cobas C311, it comes again and gives you controls, okay, for those particular tests that it gave you. If you're using a Mindray 630 something something, and then MINDRE provides controls for that particular test. Let me say ALT or AST. It means those are manufacturer controls. However, third-party IQCs, these are independent of any of the analyzers or of any of the methods. So Roche supplies the machine C311, and then you get an independent person who their major role is to manufacture internal quality controls that can be used on traverse methods. So that is what the standard recommends. We have a few providers on board. We have right now we have from RICAS. RICAS is EQA. We have Randox, where Human is the distributor. We have Biorad. We have many independent IQC providers on board. Those are third party. So third party meaning they are not connected in either way to this instrument. So that's what the standard recommends, that you either replace your manufacturer IQC with these, or you use them as an in addition to, like, you can have a procedure to just check. Because why they recommend third party is that sometimes I've seen it where you run manufacturer's controls. I mean, they are researched to ensure that they pass on that manufacturer's machine. However, when you bring in third party QC, you realize that your method is actually skewed, okay, and your results are not exactly on the mean, okay, they are skewed compared to what they are supposed to be, or they are biased. So that's about it on those. Continuing, the laboratory shall select IQC material that is fit for intended purpose. When selecting IQC materials, factors should be considered are stability with regards to the properties of interest. The matrix is as close as possible to that of the patient samples. So the matrix, the concentration of the IQC material should be close, because usually these people, when we are manufacturers of IQC, usually use different components. It could be animal blood, it could be different. So just make sure the matrix is as close as patient to patient samples, and the IQC material reacts to the examination method in a manner that is as close as possible to patient samples. The IQC material provides a clinically relevant challenge to the examination method and has concentration levels near to clinical decision limits, okay? None these things of running CRP, and CRP, your clinical decision limit for CRP is about 105, and then your IQC is in 400, okay, 500, you know. I mean, is that clean? If you run clinically, do we have those values among patients? Or levels 1,000, okay? So it should be close as possible. Excuse me. If appropriate IQC material is not available, okay, the laboratory shall consider the use of other methods for IQC. Example for such other methods. And please note that here they are saying if appropriate is not available, okay? You can use trend analysis of patients with moving average of patient results, or percentage of samples with results below or above certain values. So here you can use patient values. You can do a pooled patient sample, okay, of, you can consider patient values that, let me say CRP, you're wanting something around 8, so you have 10, 8, the 9s, pull them up, and you use those as a way of internal quality control. So how that does trend analysis of patient results, again, with moving average of patient results or percentage of samples with results below or above certain values associated with a diagnosis, okay? The other is comparison of results for patient samples on specified schedule to results of patient samples examined by an alternative procedure validated to have its calibration or methodologically traceable to the same or higher reference. So the other method is like what this one says, is you have run a sample, okay, on one analyzer. So this, let me say you have a backup. You have run a sample on an analyzer that has IQC and has also been calibrated. So you can use that same sample if the value to run on this other method that has no IQC, so that it should give you the same result. So in other words, so you've run it on something that is standard, then you're comparing it to something. Now you can be able to get that, and now run it on this other method that does not have IQC, and then you can compare these two. They should be okay. The other is just testing of retained patient samples. By retained patient samples, we mean yesterday you had IQC and you had run CBC on a particular patient C. Okay, now you get that patient. From you look at the results from yesterday and you run it today. Let me say your IQC got done. So you have to make sure that the patient had IQC yesterday. So you run it, okay, and then you should compare the results from today when you don't have a QC material to yesterday. And then if it takes long, then you do the same thing. Since this patient was okay today, tomorrow you get a patient sample today, that you ran. So that's retained sample, like that. Alright, IQC shall be performed at a frequency that is based on stability and robustness of the examination method and the risk of harm to the patient from an erroneous result. Okay, so if you're running potassium, the risk of harm of an erroneous result for potassium is high, because if you err in giving a patient a low potassium, yet it's supposed to be high, the patient could easily die. So you had better have more frequency of running that test, depending on your sample volumes. The resulting data shall be recorded in such a way that trends, shifts are detected, and where applicable, statistical techniques shall be applied to review results. I think that has been clear. So you don't just run IQC just for just. We have to see that you have recorded it in such a way that when someone is able to see in your lab, they're able to say, okay, this is a trend, there's a bias, or there are shifts. These need to be detected, or the QC is actually working normally. IQC data shall be reviewed with defined acceptability criteria at regular intervals and in time frame that allows meaningful indication of current performance. Alright, so you have to review. It's not enough just to run QC and leave it on file. It has to be reviewed regularly, and you don't say, me, I'll review after 2 months, and then after 2 months you find that your HbA1c results were all fake. So we have over 100 people who have been affected, and for high volume labs it's worse. You could have 10,000 people being affected just because you're reviewing your IQC later, your records later. So let it be realistic. You have to have an acceptability criteria. We are going to look at Westgard rules, that at what point, if the question is, at what point do I know that my QC is not actually passing? We shall talk about that. The laboratory shall prevent the release of patients in the event that IQC fails the defined acceptable criteria. Guys, yes, if you have defined acceptable criteria and it is the QC has failed, you have to make sure there's a procedure to prevent the release of patient results, okay, until the IQC issue is sorted, or until you troubleshoot, you run your QC and it's okay, then you're able to release patient results. When IQC defined acceptance criteria are not fulfilled and indicate results are likely to contain clinically significant errors, the release shall be rejected and relevant patient sample re-examined after the error has been corrected. The results from patient samples that were examined after the last successful IQC shall be evaluated. So when you run, it's not enough to run QC now and it fails. When it fails, you troubleshoot and it passes, you have to go back before you, meaning the patients near there, okay, just before the run, their results were affected. So you go back and find out, okay, their results could have been affected. So you have to go back, have a procedure to ensure that the patient results from the last successful IQC run are re-examined and evaluated to see whether or not they were actually okay. Yes, and then in case you release any patient samples on failed IQC, it is a must for you to recall and ensure that you do something that they call patient management, okay? Or if you run the IQC and it's not passing, please don't continue to run patient samples. You stop and evaluate. It's been a long one, so today we've just talked about what the ISO 15189 standard talks about internal quality control. In case you have any questions, just we're going to leave like a poll or something. Just ask where you've not understood. If you need clarity on something, I and my team will be able to respond to you. I remain Viola Nachide from VIQAP Consultancy Services. We deal in training, capacity building of healthcare professionals in laboratory, in the hospital, in areas of quality management systems, leadership in the laboratory, leadership in the hospital setting, quality management in the hospital setting, and much more. Yeah, so in case of any, and also technical issues. We also deal in you are, let me say, a laboratory or a supervisor. You really need training, but you're very, very, very busy. We also have programs to take care of, our corporate people, one-on-one. And we also have programs for our corporate teams where you want your whole team to be trained and mentored in this, or for you like, what, Viola, come on ground and let's implement these things. Let's implement the documentation, let's train the teams, and let us make the quality management system be implemented in my laboratory or in my space. We also do that for you. So all you need to do is to just reach out on our I think our numbers will be put on the screen, or wherever you get this video, there will always be a contact for VIQAP. Alright, let's say welcome to this series. Bye bye.